Thank you all for being here today. Happy spring. Hopefully it's warm where you're at and not cold sweater weather like I am in Connecticut, but it's good. Spring's always new beginnings. It's exciting. So for those of you who are our regular participants, we really appreciate you being here. And you may recall that in January, we kicked off our advocacy chat the way we do every year. And that's by having Ted Ocon and Nick Ferreros tell us what's happening at the federal level. And so it's a great way for all of our members to know what COA is focused on in 2025. But as you all know, the state level policy work is extremely important and it's gaining in importance. And that is the focus of our talk today. Our guest is my colleague, James Lee, who's COA's Director of State Regulation and Policy. And James is going to give us an overview of everything that is happening. Well, maybe not everything, but the very high level policy issues that are taking place at the state level. So James, welcome, and we're looking forward to learning from you today.
Thanks so much, Rose, and glad to be here with y'all. So we'll go ahead and dive in with our first slide here. We can move on to the next one, please. So a really important thing, I think, to begin with is really kind of helping you understand the difference between our federal and state government. So let's start with the big picture. Who really decides what kind of healthcare you receive? We have the federal government that gets a lot of attention, but it's really state government, I think, that really directly impacts a lot of daily access to care. And so first, I just want to set the stage by helping folks understand that our federal government and state governments work kind of hand in hand. They're a mirror image of each other. We have an executive on both sides. We have a legislative branch that decides what laws will be passed. And then we have the courts that kind of dispute kind of the intention of laws. And so with both governments, they really help decide the fate of a lot of healthcare programs and a lot of healthcare entities that you may be familiar with. So if we could go to the next slide, we'll take a look at some of those. So let's break this down, right? By looking at key healthcare programs and the levels of government that oversee them. On the federal side, we have healthcare programs that you may be more familiar with, like Medicare, TRICARE, and then agencies like Health and Human Services and CMS. So these entities administer large national programs and set rules for billions of dollars in spending. On the other hand, you have the states that manage healthcare programs like Medicaid and CHIP, where there's some kind of federal-state collaboration and overlap. But states also get to decide other things with departments of insurance and departments of health. We see that through the different regulatory entities that exist on the state side, that states are able to decide the types of plans that are offered in a state, the types of coverage, and a lot of different ways in which states address different regional problems that may exist within your boundaries. So with that division of power between federal and state governments, that means that two cancer patients in two different states can have completely different experiences based on their zip code. And that's really, I think, why COA, we not only focus on policy and advocacy at the federal level in Washington, D.C., but we also look to lawmakers in every single one of your states across the country. If we can go to the next slide, please. So what exactly can states do to improve patient care? State level policies have a direct impact on how quickly you can get treatment, how much you pay out of pocket, and whether your care is really personalized and tailored to you. States' impact has only grown in recent years with major court rulings that we've seen. You may have heard of one that we talk about at COA very often, which is Rutledge versus PCMA, a ruling that came out of Arkansas. We're also looking at other potential court cases that may be coming out of other states in coming years based off of legislation that's meant to be passed this year. So we're really seeing that, states can address issues from workforce shortages to insurer policies, and they can regulate everything from who can treat you to whether you'll pay $50 or $5,000 for a drug. The next few slides will walk through some of the top policies that we're seeing kind of really shape patient care in 2025. So if we can go to the next slide. So we'll start off with how states are trying to make care more affordable. One of the biggest trends in 2025 is really trying to lower out-of-pocket costs for patients. And states are really taking a look at this and trying to address this by looking specifically at pharmacy benefit managers, or PBMs. PBMs are third-party companies that are hired by insurers to manage your prescription drug benefits. Everyone, if you have some kind of insurance, whether it's Medicaid, Medicare, private insurance, everyone has a pharmacy benefit manager that is managing the prescriptions that you may have, or future prescriptions that you may have. They decide which drugs are covered under your insurance plan. They negotiate prices and accept rebates for drugs, and they get to determine what patients pay directly at the pharmacy counter. In theory, they're supposed to be lowering costs, but in practice, they often make the system more complex and really drive up costs. So how are states working to make reforms here with PBMs? The first trending policy that we look at is copay accumulators and maximizers. Copay accumulators and maximizers are really business practices that are instituted by pharmacy benefit managers. And what they do is that they say that if a patient is receiving third-party assistance for any drug, then potentially that third-party assistance may not count towards a patient's deductible and may not actually help your out-of-pocket costs. So what this looks like in practice is, let's say that you or someone you know is in need of some kind of assistance in order to pay for really expensive medications that we often see in cancer care. Well, if you have a church fundraiser, if you have a school fundraiser, or even if you have family members that are willing to pay for some of these costs for you, your insurer and the pharmacy benefit manager may say that that's not actually money that's coming out of your pocket. So somebody else is paying for that. It's not going to count towards your deductible. And at the end of the day, it's going to be harder for you to reach that deductible and then have your insurance actually cover what the plan is supposed to cover. It's a very nefarious practice by pharmacy benefit managers and insurers that ultimately really burdens a lot of patients and at times prevents patients from seeking care. We know that the cost of cancer care is not just financial toxicity, but it's also emotional burden and really dealing with the most troubling times in a lot of people's lives. And so having this added burden added to individuals is really something that is painful to see. And I think a lot of lawmakers really kind of attached to this issue because it's something that's intuitive and easy for them to understand. Now, we're hoping to see more states go in this direction, but it's kind of a two-part process where some states are trying to address the issue in its entirety, and other states are taking it piece by piece. We have to remember that a lot of the time, we need to look at government as something that is more comfortable with incremental change rather than broad sweeping change. And so in a state like Texas, for example, which previously passed a ban on copay accumulators, they're now looking at a bill this year during this session to also close the loophole on a maximizer ban. So often we see kind of a two-part process, but in some states, they try to address both at the same time. Now, another issue that that states are trying to address with PBMs is the issue, excuse me, if you could go back, is the issue of rebate pass-through policy. So rebate pass-through policy is where a pharmacy benefit manager receives certain discounts that are provided by the manufacturers of a drug in order for that drug to be offered to the formularies that they have on within each individual insurer or within the PBMs that they offer. What states are saying is that we know that PBMs are receiving these discounted rates in order for drugs to be more affordable for patients. Now, unfortunately, PBMs are taking that rebate and putting it towards profits rather than bringing it down to the patient at the point of sale. So states are saying that now PBMs either must pass down the full rebate down to the patient at the point of sale, or a large majority of that. That could look like 80% of a rebate to 100% of rebates. So these are two kind of major trends that we're seeing across the states in terms of making care more affordable. If we could go to the next slide, please. So other issues that state lawmakers are really trying to address for patients is addressing delays in care. We see this through the issues of step therapy and overall prior authorization. So with step therapy protocols, we know that oftentimes insurers and PBMs will put in place a kind of protocol that says, what we know that your doctor is prescribing you an optimal medication that may work faster and be more beneficial to you, but it's costly. So we're going to go ahead and ask you to try a less expensive medication. There may be more symptoms, more adverse effects when using this medication, but it is cheaper, so we're willing to pay for it. Unless you absolutely can't handle that medication, then we're going to go ahead and make you wait to try the medication that your doctor originally prescribed you. It's really something that complicates care for a lot of patients. As we know, with cancer, time is of the essence. And so this is a policy that's just really hard on a lot of patients, and something that a lot of state lawmakers are starting to understand, that is something that's really making for poorer health outcomes for a lot of cancer patients. And so states are really trying to address step therapy protocols, make sure that when they are used, they're used based off of evidence and real world studies, rather than just looking at costs and trying to make things less costly for the PBMs. Lastly, with prior authorization reform, there are many ways in which states are trying to address this issue for patients. We see this most commonly in streamlining of prior authorization processes. This could look like a process that requires transparency for prior authorization and notifies the patient when the insurance company requires a prior authorization for specific treatment. This could also look like making things easier for your practice, your physician, to be able to process a prior authorization, get quicker results from the insurance company or from the PBMs, depending on what the type of care is that we're trying to get you here. And so states are looking at streamlining processes, and then in other states, they're looking at more broader, comprehensive reform that is typically called gold carding. With gold carding, it essentially says that if your physician, your practice that you're getting care at, is prescribing responsibly and they have a record of having a lot of their prior auths approved by that same insurer, then they should get a break. They should have a reward called a gold carding exemption that allows them to get you care faster. So some really positive, I think, things coming out of prior authorization reform and step therapy protocols. If we can go to the next slide. One of the other ways in which states are trying to address delays in care is addressing the issue of white and brown bagging restrictions. With white and brown bagging, we see that insurers and PBMs are forcing patients to receive medications by mail delivery. Sometimes this looks like delivery directly to the site of care that you're receiving care at. This may be your individual practice, or sometimes this may look like receiving your medications directly at your door. Now, this is very complicated for a lot of different reasons. When your doctor prescribes you medication based off of the vitals that you have on the given day that you were prescribed that medication, and you have an insurance policy that requires this type of restriction, it could take 2 weeks, a month, maybe more for that medication that's required to be delivered based off of your insurance plan. It could take a very long time for that medication to actually arrive at your practice in order for you to receive that medication. And so it means that once the medication finally arrives, your vitals may have changed and you may need a different dose, a different measurement. And unfortunately, with a white bagging policy, that is, again, something that is required by the insurer, it says that you can't alter the medication. And even if your doctor has the medication in their practice, that they would be able to provide you at the proper dosage. The insurance company is saying they can't do that, and you must receive the care, or excuse me, you must receive the medication through their specialty pharmacy delivery. So obviously some really big problems with white bagging. Brown bagging, on the other hand, is a requirement that says that your medication must be delivered to your door, and then you must transport that medication to your doctor's office. Obviously, everyone lives in a completely different environment. Some people may live in places where medication can properly be stored. Other people may live in really hot climates where the medication could potentially have some really bad consequences if it's left out as you would an Amazon delivery. So obviously there's some really big problems with these two types of insurer policies. These are business policies. State governments are really trying to act on this and make sure that if your doctor is able to dispense medication in your practice while you're there, then that's more optimal, right? And we want to make sure that patients receive the most optimal care rather than wait for their medication, potentially have things get worse. So if we go to the next slide, um, the last kind of really positive thing that we're seeing across the states is the issue of coverage for biomarker testing. We know that biomarker testing is something that is really optimal for a lot of patients in determining the best route of treatment based off of their genetic sequencing. We know that some people may do better on medicine A or medicine B rather than medicine C based off of how medicines typically work with people with that type of genes, right? And so with biomarker testing, we're seeing less consequences for patients who their doctors have been able to determine the best route of care. And so states are saying if this is something that is going to make treatment more optimal and have better health outcomes for patients and their constituents, then they want to make sure that the patients within their states have the ability to get this type of care. And so they're essentially putting requirements for insurers that say that this type of care should be one, covered, and two, covered in a way that does not disrupt their care. In other words, not putting prior authorizations or delays in getting that type of testing and potentially sometimes receiving more than one test, right? And so this is another, I think, positive development that we're seeing across the country when it comes to patient care. When we go to the next slide, we want to also share with you some concerns that community oncology practices have when we're looking at the states. Well, there is a lot of positive developments. At times, we have seen some bills that do give us pause. And the first bill here on this slide is the expansion of 340B contract pharmacies. Now, the 340B program was something that was created around the 1990s and really over the last 20 to 30 years has been infiltrated and abused by large health systems and pharmacy benefit managers. There are still entities that do use the funds properly, but we have seen documented publicly a lot of large hospital systems and pharmacy benefit managers have been using the program to increase profits. And that is ultimately impacting the type of care that is available within your state and the cost of care. When we see large hospital systems kind of boost their profits with this program, we see that they force independent practices to compete in ways they cannot force and ultimately push them in the direction of being consolidated or acquired into the health system. What that ultimately means is that sometimes large health systems will buy out smaller practices, close those practice locations, and make it to where you have to drive further or travel further within your state in order to receive care. That also drives up the cost of care. So with contract pharmacies, we're also seeing that pharmacy benefit managers are now getting into the program, and we know that pharmacy benefit managers are for-profit entities that have made it harder for a lot of patients, no matter if you have cancer or any other disease state, they've made it harder for you to get your care. And they also make it harder for independent practices to operate efficiently and sustain themselves. Well, through the 340B program, um, pharmacy benefit managers are trying to get approval and be contracted with more and more 340B entities to get the benefits from this program. And what we're seeing is that they are going further and further into more affluent communities with contract pharmacies. And so the expansion of the 340B program to allow more contract pharmacies and PBMs to infiltrate the program is something that states are looking into. COA has been putting a voice to this and kind of shedding light on the issue. It's something to be aware of that could potentially impact your care. The last thing here is reimbursements and state drug boards. There is a trend that is going across the country that's called prescription drug affordability boards, or PDABs, as you might hear them more commonly referred to. In theory, these boards are supposed to look at the costs of medications and recommend a set price that limits payments to providers for these drugs. And while in theory it sounds like a good thing, often we see that these PDABs are not including oncologists, specifically independent oncologists, in conversation. And that kind of puts reimbursement concerns on the table for a lot of practices, because these boards have the power to limit the reimbursement that your provider, your practice receives, and could potentially mean that your practice is really taking on significant financial burden when they're purchasing drugs and then not being reimbursed for the same price that they needed to pay for these drugs. As you might see within your practice, right, there's a lot of things that go into place where we're talking about cancer drugs. It's not very simple, right? There's added team members that need to be hired in order to process some of these drugs. There's added safety protocols and temperature, like we were talking about earlier. And these types of issues are not really being discussed within these state drug boards. We're also trying to raise this conversation and make sure that one, that they are aware of the consequences of some of these policy proposals, and two, that oncologists' voices are being heard. If we could go to the next slide. So as we kind of wrap up here with this conversation, we want to make you aware that there are a lot of good things happening at the state level, some things to be concerned about, but really we just want to make sure that you are paying attention to your state capitals as much as you are to Washington, D.C. There's a lot happening, as you can see, and that just kind of touches the surface of the different policy issues that we are tracking all across the country. There are many different ways that you can get involved with state policy, no matter what state you may be in. The first way that I would recommend that you kind of go into this process is really work with your practice. A lot of your practices are very involved with COA. And if they're not involved with COA, we're working on getting them involved with COA. But your practices are going to be very acutely aware of the state policies that are impacting the delivery of care and you ultimately. So they're going to be a good first step for you to go to and talk to about how can I help, right? The second step that I would say is your lawmakers all across the country really want to hear from you directly. And so if you don't already have a relationship with your state lawmakers, it's something that you can start and begin to form. State lawmakers are not like your federal lawmakers in Washington, D.C. Your state lawmakers are often most likely your next door neighbor in a neighborhood nearby. You'll see them at the grocery store. You'll see them at church. You'll see them at school. You'll see them all across your community once you understand who they are and you recognize their face. So they're much more accessible. So something to think about is to determine who your state lawmakers are and determine what kind of overlap you may have with them in the community, and how you might be able to support them and helping educate them on the issues, because they're hearing a lot of the time from the insurers and the pharmacy benefit managers, and too often not enough from patients. The last thing that I would say here is that when the time arises, there's also opportunity for you to share your personal experience, whether this is providing testimony, or maybe this is writing a letter, or even just calling into your state lawmaker's office and saying, hey, I've heard about this legislation that's currently under consideration at the state legislature. I really just want to express my opinion here based off of my real world experience and the care that I've had, and really help out in that way. And I know that Rose contacts a lot of you and the chapters with this kind of information, so be on the lookout for that as we move forward with working more and more in state policy. With that, I'll turn it back to Rose.
James, this is really great, fantastic information. I have a few comments I want to make, but we do have a question. I'm not sure if you can see the Q&A. If not, I will read it to you. One of the bigger challenges to insurance or PBM reforms at the state level is that ERISA plans are excluded from the application of the law. Is there anything that can be done at the state level to make their laws inclusive of self-funded plans, or does that need to be done at the federal level?
That's such a great question. So at the start of this webinar, I shared with you all that the process with changing policy happens in many different ways. We have the executive, the legislative, and the courts. Right now, you have a very interesting development happening in the state of Texas, where the state of Texas has recently passed groundbreaking PBM reform in recent years, but PBMs are trying to skirt around following the new law by looking at and pointing to ERISA, which is federal policy. ERISA is federal policy that protects independent small businesses from being forced to apply a lot of different regulations to their business. Now, when we look at ERISA, the state of Texas is saying PBMs are trying to use this as an excuse for not following the law. So the state of Texas asked for clarification from their attorney general. The attorney general said, that's not what you're doing. You're not trying to change plan design or benefits. You're trying to regulate pharmacy benefit managers, and they're just using this as an excuse. What's happening right now in Texas is that they're codifying the attorney general's opinion, and we expect to see some really big court cases that are going to be filed by PCMA and others against this, moving forward with enforcing PBM regulations, despite the plan type, whether it's ERISA or self-funded plans. And so we expect to see within the next few years that court case unwind at the federal level through the Supreme Court, and hopefully another groundbreaking decision by the Supreme Court. So really something to look forward to. If you're interested in looking more into that, it's Texas SB 1122, and happy to talk with you more offline.
Thank you, Jane. Also, I really appreciate throughout your presentation, you're talking about the patient impact, and obviously a lot of these are policy issues. Some of the terms, people in our audience are familiar with, especially the COA topics that we've spent a lot of years talking about, PBMs. But at the core of all this is real life patients. And on the 340B slide that you had, I believe you used the word vulnerable patients related to that particular issue. But all cancer patients are so vulnerable, and all of these barriers and frustrations and delays in treatment, it's agonizing for patients. So it is a good thing that we're out there, advocating to change policy, because there's real people that are affected by all of these issues. So it's good to know that we have a way to, add our voices to these frustrations. So I'm glad that you covered a lot of these. And speaking of, I also liked your last slide, which is a picture of us on Capitol Hill. Want to let everybody know that we are officially going back to Capitol Hill on June 11th. If you are a cancer patient, survivor, or caregiver, we have some scholarship money available, so save the date, June 11th. And also, as Jane mentioned, we'll have a lot of people from our practices there as well. So if anybody else has any other questions, you can certainly reach out to me. I can forward it to James, or I can give you James' email. James, did you want to add anything else before we go on to one more slide?
No, thanks so much. Pleasure talking with y'all.
Thank you all. And if we can go to the last slide, thank you, James. Next month is National Oncology Nursing Month. And one of the other things we like to teach about at COA is having you get to know a little bit more about the oncology care team. And we all know how much we love nurses. So please join us next month, May 14th at 12 o'clock Eastern Time. Our special guest is Shannon Bezelman, Clinical Manager at Northwest Medical Specialties in Washington. And thank you again for your time today. And thank you again, James Lee. Enjoy the rest of your day.